Hi, everyone, and welcome back to the CDC Field Epidemiology Training Program webinar series. We are delighted to have you with us today for another technical webinar. Next slide. Field Epidemiology Training Programs, or FETPs, are competency-based training programs that strengthen the epidemiologic capacity of the global public health workforce in more than 90 countries globally. FETP fellows and graduates detect and stop outbreaks, improve surveillance systems, and strengthen public health programming across both infectious and non-infectious diseases. As you know, every month we showcase a photo from a different FETP on this slide. And today we wanted to honor our colleagues in the DRC. I think everyone on the phone is very aware that in the DRC, they are battling a very large outbreak of Bundibugyo Ebola virus. And we know that our FETP colleagues are playing a central role in some of the most important parts of response. On this slide, we have a photo from Dr. Esperant, an FETP graduate in DRC, showing him investigating a suspected Ebola case in Ituri province. We can go to the next slide. I received so many photos from DRC, and I wanted to share at least a few more so we can honor our colleagues there. So here are Dr. Kathe, and I apologize if I'm mispronouncing, Dr. Matadi, Dr. Steve, and Dr. Alain, conducting active case searches, contact tracing, and case investigations. For our colleagues in DRC, thank you for the important work you're doing. We know that you have a long and difficult path ahead, and our thoughts are always with you. Next slide. So today's webinar, like all our webinars, will be 90 minutes with about 1 hour of presentation and about 30 minutes of Q&A afterwards. We have live interpretation for today's webinar in Spanish, French, Portuguese, and Russian. And on the lower part of your screen in the navigation bar, you can choose your preferred language. We will also be asking, as we always do, for a very short evaluation of the webinar. The evaluation is required for you to receive a certificate of attendance for the webinar, and that link will be shared at the end as a QR code. Next slide. During today's webinar, I want to remind everyone that if you have questions, please use the Q&A box and not the chat box. You can use the chat box to chat, but the Q&A box is where the questions need to go. It is available at the bottom of your Zoom screen. And if you ask a question in the chat, we probably won't see it. So put those questions in the Q&A box. Next slide. Okay, so with that, I am very honored today to introduce our presenter, Dr. Richard Garfield. Dr. Richard is the unit lead for global health security at the Division of Global Health Protection at CDC headquarters in Atlanta. Dr. Richard is a nurse and an epidemiologist working across many countries to assess, finance, plan, and implement global health security activities. He has lived in and worked with ministries of health in 4 different countries and was previously a staff member at the World Health Organization Emergency Response Program in Geneva. He is a professor emeritus of nursing and epidemiology at Columbia University in New York City, and he's an adjunct faculty member at Emory University in Atlanta. So with that, I'm going to turn the webinar over to Dr. Richard.
Thank you so much, Julie. And I warmly greet everyone on this webinar. I wish I could be with you in your places because you are the people I really care about. Today, we're going to talk about timeliness analysis. You may have heard of this already. What we will show you is what timeliness analysis is, how to use it, and when it's most useful. We also use the term 717 as a shorthand way to describe timeliness analysis. But the proper title name is timeliness because it doesn't necessarily meet those 3 numbers. Here we will use both terms because 717 is quick and easy. I want to start this webinar with an example that demonstrates specific aspects of timeliness. We start here on January 10, when 12-year-old Joseph became ill. He develops a headache, fever, and loss of appetite. Because these symptoms are common to many illnesses and sometimes go away on their own, his family waited to see if he improved. But he didn't get better. And late in the day on January 15, his family took him to a hospital which was 30 kilometers away. On January 17, while in the hospital, Joseph's condition got worse. He developed bleeding, fever, and jaundice. Jaundice is a yellowing of the skin. At this point, his condition was quite serious, and the hospital took a blood sample for quick testing. They wondered if he might have yellow fever. And the next day, on January 18, testing of his sample confirmed that he had the yellow fever virus infection. Here we're reviewing that timeline of events for Joseph again. His first symptom appeared on January 10th, and his diagnosis was on January 18. That means it took 8 days to detect the infection. By the time Joseph was diagnosed, the outbreak had spread, as you can see with these arrows, and there were 20 cases and 8 people had died. This all happened within the 8 days it took Joseph to be diagnosed. Was there a way to prevent these additional cases? What if Joseph had been diagnosed earlier? There could have been a wider search for cases and isolation of any that they found, so fewer people would have been infected. This is the heart of timeliness analysis. Timeliness analysis 717 is a set of specific time targets to detect outbreaks, to notify authorities about the outbreak, and to initiate the response. The first 7 is for detection. That's shown by the red shape on the left side of this image. We want it to take no more than 7 days for us to detect an outbreak from the date that the public health threat emerged, meaning the date that the first symptoms occurred. The date of detection is the date when the event was first recorded by any source in the health system. This can happen at the community or the health facility level, through a laboratory, or through the surveillance system. Again, the time between the emergence on the far left in purple to detection in the red circle should be 7 or fewer days, we hope. The next number in 717 is for notification. That's shown in the orange circle in the middle. This number is 1, meaning it should take no longer than 1 day from detection for us to notify a public health authority that the outbreak has occurred. This can be at any level of the health system. Most commonly, it is a district surveillance officer being notified by a nurse or doctor of the health event. The time between detection and notification, from the red circle to the orange circle, we hope it will be 1 day or even on the same day. Finally, the last number is a 7 again. This is shown by the green shape on the right. This number refers to how long it takes for us to start all the early response activities once notification has occurred. In general, for most outbreaks and most countries, we should be able to go from the emergence to response from the beginning to the end of this slide in 7 plus 1 plus 7 days, a total of 15 days. But each of those three components should meet its milestone for the timeliness target of 7, 1, and 7. Together, these three metrics form the overall 717 timeliness target. Assessing actual performance against this target helps us identify how we're doing. I have to take a step back now to give a wider context. Timeliness analysis fits into the bigger picture of health security, and health security is a big field in public health. Our work is based on the international health regulations that you can see on this slide. We call that IHR, International Health Regulations. The IHR is a treaty requiring all countries to do things to reduce the impact of disease outbreaks. It is the international law that forms the basis for health security work. I want to ask you now, have you heard of IHR before? Do you know any of the tools or instruments that countries use to assess their health security? Please take a minute or two to record, to write down anything of IHR that you have heard and that you know. I'll give you a little time now to do this. And Julie, I don't see their responses, so how do we handle this?
Lots of people are saying yes. A couple of people are saying no, they've never heard of it. Some people are saying Appendix 1 and 2, decision instrument. So lots of familiarity with IHR, but still some folks who are not so familiar. So great that you're going over it. I'll send it back to you.
Those responses, including the details that some people mention, all of that is part of international health regulations. Our international health regulations has been the law for many years, and CDC has done a lot in the last 15 years to strengthen it. In IHR, we have tools to measure things, to see how countries are doing. And there are many tools. Not all of them are needed, but some of them are common or basic. And I think many of you have heard or taken part in some of these. The Joint External Evaluations, JEEs, that's a global assessment of a country's capacity to detect, notify, and respond to public health, to disease outbreaks. Capacity is what a country can possibly do. The majority of countries in the world have carried out this big JEE evaluation sometime in the last 5 years. Many of those countries went on to make national action plans based on their JEEs of what they would do to strengthen health security. And every government is responsible, every government of a member state of the World Health Organization is responsible to send to WHO in Geneva a summary of their own capacity assessment in key areas each year. It is much smaller than the big JEE. But together, all of these tools are still focused only on capacity, meaning what a country may be able to do to deal with a disease outbreak. And the final bullet on this slide is different. After action reviews assess what actually happened in a real outbreak. After-action reviews have also evolved. The tools change over time as we find the need to make them more relevant. So after-action reviews have moved to become more specific to the time period being examined. Early action reviews, as the name sounds, early, involve examining the beginnings of a response in real time while the response is going on to identify refinements that may improve the ongoing response. That's early action review. Interaction review take place during the outbreak as more experience is gained, again, to refine the response and address gaps. That's if there's a longer outbreak. And then after action reviews, the original approach may involve a hot wash immediately at the conclusion of a response to identify lessons to be learned while everyone's memory is still fresh. They may also involve more in-depth examination of all aspects of the response. 717 that we're talking about today build on the guidance for early action reviews. I'm going to compare the biggest tool to the most recent and more specific tool. The JEE, the Joint External Evaluation, is the most broad IHR tool. 717 is the most specific. I contrast them here. The JEE estimates what a country can do in many areas, while the 717 specifies what actually happened. The JEE involves many people over months to develop a view of the entire health system. 717 can be done quickly as part of an outbreak response. The JEE is such a big effort that it can only be done once after around 5 years. 717 can be done for any or all outbreaks. In the last few years, several countries have collected information for more than 1,000 events using 717. We're going to get now back into the metrics that make up 717. There are 4 dates that we need when calculating 717. The first is the date of the public health threat emergence. This is based on symptom onset of the first case for a condition, a non-endemic disease, meaning something that wasn't there already, or when a predetermined level of increase in case incidence over the baseline rate occurred if it's an endemic disease. The second date is the date of detection. The date of detection is the date when the event was first recorded by any source or in any system. This can happen at the community or health facility, through a lab, through the surveillance system, any of those. The time between emergence and detection should be 7 or fewer days. The third date, the third number, is the date of notification. This is the date that the event is reported to a public health authority responsible for action. This can be at any level and often occurs subnationally, like at the local or district level. Think of a district surveillance officer being notified by a clinician of a suspected case, a suspected event. The time between detection and notification, again, should be 1 day or even less than 1 day, same day. The fourth date, to make our 3 different time periods here, is the date on which all applicable 717 early response actions have been carried out. To determine this date, you need to assess the dates of the 7 early response actions that are common and use the last of those dates, the last one to begin. We'll go over those actions in the next slide. The time between notification and completion of all applicable 717 early response actions should be 7 days or fewer. Together, these 4 calendar dates give us information for the 3 metrics that form the overall 717 target. Assessing actual performance against these targets helps us identify where we think we did well and where we did not do as well in dealing with an outbreak. Now, what are the common early response actions? Each kind of an outbreak has a specific set of response actions that should be taken. Here are the 7 most common actions. To initiate an epidemiology investigation, to analyze epidemiologic information and do a risk assessment, confirm the diagnosis by a laboratory, if there is a laboratory test for what we believe the condition to be, to treat those who have become ill and prevent the disease from spreading in a clinic or hospital, to initiate public health countermeasures to reduce transmission, to initiate risk communication and community engagement, and to establish coordination among those involved in the response. I'm going to recap now how to use the 3 numbers of 717. We calculate the 3 numbers from the 4 dates. From the date of emergence to diagnosis is detection. From the date of diagnosis to reporting is notification. And from the date of reporting to initiating the actions is response. So going back to Joseph, who we mentioned at the top of this session, did we detect? Our analysis is now looking at these 3 numbers and asking, did we detect in 7 or less days? Did we notify in 1 day or less? And was the early response mobilized in 7 days or less? I'm going to ask you again to write in so that Julie can see your responses. Did we detect in 7 or less days?
Okay, so we're getting everybody saying no. One person says yes, but most people are saying no, we did not detect in 7 or fewer days.
And you are right. It took 8 days. So it's almost 7 days. It's not so terrible, but we can do better. Did we notify within 1 day?
Let's see, we're getting mostly yeses. A couple don't knows, but mostly yeses.
Because you can't see the timeline slide, so
Yeah.
you have to remember. Yes,
Yeah,
we
so
did.
I think, yeah, go ahead.
We did notify within 1 day. And usually people do. Was the early response mobilized in 7 days or less after notification?
We have a couple maybes, some yeses and some nos. I think mostly yeses. I think folks are having a little bit of trouble remembering that opening slide.
But also, this is the one that's more complicated, so it's no surprise that you're saying maybe.
Mm.
There are many different actions. Which ones had to be done for this case and which ones were done? It takes us more effort to determine this metric than the others. So I like the answer maybe. Once we have calculated these three numbers and determined whether we met our goals of 7, 1, and 7, we're not done. That's just the start. Then we analyze and act. Then we can ask, what bottlenecks prevented us from being able to detect, notify, and response faster? We also ask, what enablers helped us to detect, notify, and respond as well as we did? Even if we didn't meet all three numbers, something was going right, that it wasn't worse than it was. And the point is, when we've identified the bottlenecks and enablers, what actions can be done to reduce the bottlenecks and build on the enablers identified? Then we have the opportunity to do the actions, and in the next outbreaks, see if the results changed on the time it took to notify, to detect, notify, and respond. We find that there is a big impact from timeliness analysis in many countries. Some people work in epidemiology or lab, or physicians or nurses in medical care, or people involved in countermeasures. But if we're doing the 7, the 1, and the 7, we go through the various steps and we overcome limitations in any one or across these fields. Timeliness involves not any one of these alone, but all of them together. Timeliness requires us to deal with all of this, tying together in one system from the first symptom to the mobilization of the response. We call this, when we're doing a good job, continuous quality improvement. The big job, once we have the numbers, is to identify bottlenecks. And I know most of you have done this before, but we get very specific here because we want to engage specific actions. We never had the opportunity to get so specific as we do once we have the numbers of the 717. Every JEE and every after-action review that I've been part of includes that we need to train people. By looking at the information we have now on detection, notification, and response, we can get much more specific. So, train who should be trained. We know from our 717 we need to train the first contact health professionals at a clinic because detection took too long. What do they need to be trained to do? They need to be trained to recognize the signs and symptoms of yellow fever. It says measles, that's a mistake. It's yellow fever in this case. How shall we train them? Well, each situation is different, but one example would be to take the regular staff meeting that already occurs on Fridays and provide a remote presentation that includes the information on our outbreak and an image of a typical rash from yellow fever. Once bottlenecks are identified, corrective actions are identified. That's what we have just done. We've gone from bottleneck to action. And when we have our actions thought through, we can specify that the immediate actions are those that can be taken quickly with existing funding, staffing, or programs. Longer-term actions, on the other hand, require additional resources or staffing. They may involve different levels of the government. They may involve external partners or things that just take longer to do. It's essential that the proposed actions directly address the identified bottlenecks. After an outbreak is over, it's easy to make a long list of the things that went wrong and to also list many things that should be fixed. But what really making sure to focus on what didn't work well and then linking each bottleneck directly to a corrective action is what will really strengthen the health system for the next outbreaks. Now I will use an example of a measles outbreak this year in the Philippines. This is a real-life case. In the first quarter of this year, a measles outbreak was identified in the Philippines. Early data suggested that low vaccine coverage was a major factor in the outbreak. On the 16th of March, the first case had an onset in the city of San Mateo in Rizal province. So that's the beginning of our count, the onset of symptoms. On the 23rd, the outbreak was detected when a child and his guardian went to a clinic for his rash and fever. On March 24th, just one day later, San Mateo notified the provincial health office that they had a case of measles. And on March 30th, 6 days later, they had completed the initiation of the early response actions, including case investigation and a mop-up vaccination campaign. So how did it work? Here are the dates that I just mentioned. And here's how we can easily summarize timeliness analysis for an outbreak all on one page. The timeline is divided into detection, notification, and response. The emergence to detection was 7 days. Detection to notification was 1 day. And notification to the initiation of all the early response activities was 6 days. So it met our goals. But still, they identified bottlenecks. Remember, it took 7 days to detect. That's good, but it could have been better. Why did it take 7 days to detect? In the evaluation, the team found that the patient was late seeking care. Both the index patient and the guardian knew little about measles. In fact, they thought what the patient had was a normal flu. So as a result, measles was not detected sooner. At the same time, there were some enablers that facilitated detection. When they did the 717 review, the team noted that most of the community health staff had already received training in detecting notifiable diseases. This meant that when the first clinician saw that first patient, she knew what she was seeing and could recognize it and make the notification right away. In addition, the team identified facilitators to notification. Notably, the team was already using digital platforms and group chats to submit case investigation forms and report health events to the Epidemiology and Surveillance Unit of San Mateo. That meant that no one had to carry paper forms anywhere and that the measles case could be notified as soon as it was identified. When it came to the response, two main bottlenecks were identified. Because low vaccination had been identified as a major facilitator of the outbreak, the team wanted to respond quickly, but there had been too few vaccines and only one vaccine carrier in the provincial health office. They didn't have enough vaccine. This limited the speed that they could carry out the mop-up vaccination campaign. And second, although the team was meant to keep a list of vaccine defaulters, it hadn't been updated, but because the community health workers had been assigned other tasks. This meant they didn't know exactly who still needed vaccination at the start of the response. Finally, they did note multiple enablers for the response. First, community health workers were already trained not only in case detection, but also field investigation, and a protocol to respond to suspected cases already existed. Second, they already had specimen kits pre-positioned in health units so they could collect samples quickly and easily. Third, they had set aside dedicated resources for specimen transport in that year's budget, so they weren't struggling to figure out how to move the specimens that they collected. And finally, they were able to borrow staff from other health units to support the vaccination activities. Once they had identified all these bottlenecks and enablers, they were able to take action. The immediate actions included a community assembly in the affected region to discuss measles with people from the community and plan for its emergence in other provinces if that occurred. They also asked for additional vaccine carriers from the Center for Health Development and arranged a meeting with the local captain and health counselor so they could emphasize how important it was to map the vaccine defaulters. They also identified longer-term interventions, including asking the San Mateo Health Unit to get more vaccines and carriers so that they could respond more quickly in the future. On this slide, you can see clearly how looking closely at both the barriers and enablers to rapid response in an outbreak led to direct, immediate, and longer-term actions, even in a situation where the 7 metrics were met. Imagine how useful this could be in a situation where they were not all met. We are always facing some successful aspects and some limitations. Having this analysis permits us to identify specifically what to do now, what to do later, for a process of continuous quality improvement. Now I'm going to a different example that Julie knows very well because she was involved. This is another example on which some of the 7 metrics, excuse me, where some of the metrics were not met. On the 5th of August in 2022, the first patient with the Sudan strain of Ebola virus started in Mubende district in central Uganda. Mubende is about 150 kilometers west of the capital city of Kampala. On the 17th of September, 46 days later, the first patient was diagnosed with the Sudan Ebola virus at Mubende's regional referral hospital. On that same day, notification was occurred and the outbreak was declared. And on the 26th of September, 9 days later, early response actions had all been started. So it's a very different situation. Early investigation identified many suspected cases before that index case, because it took 46 days, suggested that most patients went to private health facilities and therefore didn't get notified as they should have been. So that was one of the problems that they found later when they did the timeliness analysis. And here you see the timeliness analysis for this Uganda outbreak of Ebola. The dates that you see there under the colored graphics are the dates that I've just mentioned from before. So you see detect was not done within 7 days. Notification was done, and response took 9 days, a little more than the 7 days. It's a very different situation than the one we had for measles in the Philippines. So instead of 717, we have 4619. This timeline focused attention at the Uganda Ministry of Health in determining what led to the delays. As they looked at bottlenecks to detection, two important elements were identified. First, they found that there was little knowledge about the IDSR suspected case definitions or notification protocols for private health facilities. This meant that even if private facilities had identified something suspicious, they might not recognize what it was or report it. Second, they found that community-based surveillance was weakened due to the constant efforts required as they were in the middle of the COVID pandemic and they were busy working on that. In terms of enablers, the initial case had been recognized at the hospital because there was ongoing syndromic surveillance for acute febrile illness and other diseases. A staff member who had been trained in surveillance suspected that the patient might have a viral hemorrhagic fever disease and notified the district, which led to the patient being tested and the outbreak being identified. Although notification happened within a day, there was still an investigation to potential barriers. Two potential barriers were identified that could have delayed notification. These included the lack of clear roles of who to notify if a suspected case was identified, and a lack of prepaid SMS messaging service to use for notification. Despite this, they did notice that the hospital immediately called the district rapid response team and notified them about the case. So that was an enabler. Initiating the early response actions all took a total of 9 days, largely related to the challenges with an isolation unit and contact tracing. First, they created an isolation unit at the hospital using an empty ward of the hospital. However, that ward lacked sanitation facilities, which is especially critical for patients with Ebola. And this delayed rapid response. Second, there were delays in accessing funds for contact tracing teams. Contact tracing is an essential intervention to prevent the spread of the Ebola virus. And being able to send out teams quickly is critical in outbreak control for Ebola. However, they did find an enabler as well. That early response from the regional referral hospital was its ability to mobilize resources so that initial investigation of the cases and deaths that occurred before the index case was quickly identified. This analysis overall motivated the Ministry of Health to engage private healthcare facilities, recognizing that many patients would go to private facilities first. They also were able to find space for an Ebola treatment unit with better conditions, excuse me, for isolating and treating patients. They also focused to identify partners to support expanded contact tracing. So those were the immediate actions that they engaged in. Engaging private providers, identifying a better isolation unit, and identifying partner funds to facilitate contact tracing. Over the long term, Uganda increased their trainings for private facilities and engaged them in outbreak detection, prevention, and control. In the end, Uganda then had another outbreak of the Sudan Ebola virus the next year in November 2023. By January 11 of 2023, the outbreak was declared over. Once the response began in Uganda, it was highly effective. So we're talking about the next outbreak of the Ebola virus, that particular type
Richard,
of
I'm
Ebola.
sorry that
Yeah.
this is actually the same outbreak.
Oh,
I think just the year is wrong. So this is actually just a summary of the 2022 outbreak. And I
oh,
think
sorry.
that's my fault. I put the dates
Yeah.
in wrong. Sorry.
Many of these cases and deaths could have been prevented with earlier detection and treatment. And with 717, now they knew the steps to do to be successful. I'm going back now to the Philippines to this year, because in the region that we visited before, they had a total of 6 measles cases, each one emerging without a connection to the case that we saw. So they treated this as 6 different outbreaks. They have identified 6 outbreaks in that region this year so far of measles. 6 persons, meaning 6 outbreaks. And what they did was they analyzed each one, and then they put the data together for all 6. And that's what you see here. For the 6 cases, the 6 outbreaks, they found that 4 of them were identified within 7 days. And 4 were notified within 1 day. So that's 2/3 met the detection target and 2/3 met the notification target. But most of the need for improvement in timeliness analysis for that region for measles is in the response, where only half of the events mobilized the full response within 7 days. This group analysis helps to identify which bottlenecks and enablers are common across the region and which would be different or unique to a local area. This is a systematic analysis that it's more systematic and more detailed than what we do when we have an after-action review, which looks at lots of things and makes lots of general recommendations most of the time. It's focused on strengths and weaknesses of the health system, not by pointing fingers at individuals who might be blamed for not doing a good job, but looking at the systems and what needs to be improved in the systems. So 2/3 did meet detection, 2/3 did meet notification, half of them did meet the target. But if you look at all of them together, only 1 of the 6 met all 3 numbers well. So they found that they did not bad, but there was room for improvement. Now that we've looked at these different cases, I want to summarize for you what's the value and the uses for timeliness analysis. The first use, and the use of greatest concern for CDC and for health ministries, I hope, will be continuous quality improvement. That's the heart of it. Now that we've got the timeliness targets and we can count, there's a clear process to follow to assess, determine bottlenecks, and identify actions to drive improvement from every outbreak to the next. From the examples, also you can see that the data provided clear and simple findings to inform prioritization of actions that help in advocacy to get the resources and the policy changes that were needed in order to improve. So that's advocacy. First, it was performance improvement, then it's advocacy, and finally, it's accountability. Evaluating performance against these basic simple metrics simplifies monitoring and improves transparency in reporting, making it easier to demonstrate the impact of the interventions. Altogether, by improving performance, by having a tool for better advocacy, and for the accountability of how the system's working, we really are able to improve health security. Next, I'm going to talk about a larger group analysis done in another country. Here we're using timeliness analysis to compare disease groups, not just the same disease outbreaks of the same disease in different places, but different outbreaks of different kinds of diseases. We're looking at a total of 678 outbreaks of disease grouped by category. And this is all in one country. These are real data. There were 78 foodborne outbreaks, 25 respiratory disease outbreaks, 100 viral hemorrhagic fever outbreaks, and the biggest number is 157 diseases that are vaccine preventable. Then they had 21 vector-borne disease outbreaks and 22 others. You can see that for detection, they did pretty well with food and waterborne diseases at the top. 88% were within 7 days. They did the poorest with vector-borne diseases near the bottom, where only 57% of the outbreaks met the target of 7 days. In notification, they did pretty well with across the different diseases, but the weakest was among respiratory diseases and vector-borne diseases at 62%, meeting the 1-day indicator. And in response, only 58% of the outbreaks of the whole 678 outbreaks met the response target goal. Response was weakest there among vaccine preventable diseases, with only 41%, you see the red, of the responses happening within 71 days. And finally, if you put the three numbers together, only 37% met all three timeliness goals. This shows that there's a lot of room to improve, but the improvement was needed more in some disease groups than in others. So what is it about the vaccine preventable diseases and vector-borne diseases that caused lower performance? This helps us to focus on the weakest areas. They went on to do analysis within the vaccine preventable diseases, and that's what you see on this slide. Just looking at various vaccine preventable diseases, we can see a huge variation between one disease, one outbreak, and another. At the top, you have monkeypox, then there's shingles, hepatitis A, and diphtheria. That's all on the y-axis. On the x-axis, on the bottom, you see the number of days calculated. And you see the broken line, the dotted line shows that first dotted line is 7 days. Then you add another dotted line for the 1 day, and the third dotted line for the last, for a total of 15 days. You see that at the top of this graph, it was monkeypox that took the longest time to detect. Detect is the blue part of the bar. All the other diseases were detected in a shorter period of time than monkeypox. And the longest for notification was whooping cough, a little lower. You see that the red, the time to respond, was longest for whooping cough. Whooping cough also had the longest time to notification. The other vaccine preventable diseases had a much shorter time to detection, notification, and response. So improving timeliness for vaccine preventable diseases would be achieved by focusing mainly on monkeypox and whooping cough. And the problems now, they could look into why were those longer than the others and what needed to be done to improve them. So you see, you can get very specific to know what bottlenecks for which condition, where, and when. I've now told you most of what I wanted to show you so that you know what timeliness analysis is and how we use it. Now I want to tell you good news that there is a group of countries all working together, sharing their information, sharing what they learn about their outbreaks, and sometimes, if they choose to, sharing the data of what they find in 717s. This is not something that CDC is doing. This is we are working with others, and this is a map made by the 717 Global Alliance. 717 was originally piloted in 7 countries in Africa and the Americas. And now this was actually some months ago, so there are more now. There are more than 93 countries that are part of the 717 Alliance. Major international funders are promoting 717 because they have the need for accountability. And governments are using 717 to see how to improve. This alliance is being led by a non-governmental organization. The name is Resolve to Save Lives, which was started by a former CDC director, and we work closely with them. They are working in many countries, sometimes same countries with us, and sometimes we work in one country, they work in another. This alliance is a forum for countries to learn from one another, and the slide shows you that there are countries in every part of the world and more taking part in this alliance. If you want to learn more about 717, and if you want training, you can go to the 717 Alliance website. All you have to type in is 717, and this is the screen that comes up. And then you'll reach this homepage, and you see all the different resources that they have available. One of those resources is this data dashboard where they've reported on about 750 events of 717s from 35 different countries. So the more events they collect, the more analysis can be done by region and by disease category. They are now working, Resolve to Save Lives from the 717 Alliance, to create a downloadable template so any country could take the dashboard for their own data and events and use it in their own country. There is no single approach to how to implement to become successful at doing 717s. Countries have used various approaches. Some are more top-down from the central government, and others are more bottom-up from local communities to successfully implement the strategy. And here I'm going to show you common steps across what we know of the various countries. The first step is training, like what we're doing here. It is ideal to have stakeholders from multiple levels in the public health system, as well as other sectors, including animal health and the environment, involved in training. It may start at the national level, but it must reach regional and local levels if it's going to be effective. The next step is to gain skill in analysis of the outbreaks for which data is collected. The closer the analysis is to the local area where the outbreak happened, the more immediately useful the results can be. And as you continue analyzing outbreaks, you will find gaps and errors in some of the data. Data systems may need some adaptation, and skill at identifying bottlenecks evolves over time. If they are not yet involved, this is also the time to involve other sectors or institutions where the diseases may be relevant to them or where they may have responsibility to be involved. Eventually, after those first three steps, 717 has to become institutionalized. This is because no matter how well you plan and implement the basic process, each country is different and its needs and organization is different. So every country has to figure out who will lead the effort, who maintains the database, and who leads the staffing to do this. We call this finding the institutional home for 717 in a country. And finally, the institutionalized process, by which stage we've analyzed a large number of outbreaks over time, will be yielding data and success stories that you can share, facilitating collaboration between countries or regions, regions between countries, regions within countries, and you will have the evidence of your success in helping you build the case for resources and strategies to continue to improve health security. In the country of Uganda, we were having successes over time. So here's one more example where we in CDC have worked with Ministry of Health in Uganda to track Ebola outbreaks over many years. During 2018 to 19, an Ebola outbreak took 4 months to detect and resulted in more than 2,000 deaths that you can see here on the first line. In 2020 and 2022, there were subsequent outbreaks of Ebola, and they took each time less time to detect, and they resulted in fewer and fewer deaths. But things don't always move in one direction. An outbreak that started this year with a different strain of Ebola in a remote and insecure area took more than 3 months to detect. And to date, there have been more than 500 deaths from that current outbreak. So things change, biology changes, things evolve. That's why continuous quality improvement requires us to keep an eye on things and monitor and measure to see where we have successes and where we don't, to know how to fix the problem quickly. Finally, I want to talk today about opportunities and roles for FETP trainees and graduates. Some FETP programs have already integrated 717 training into their outbreak investigation work. I think there will be more of this coming soon. There's important work at each level of FETP in timeliness analysis. Our colleague here in Atlanta, Sandra Bedoyan, has proposed the following roles for FETP trainings and graduates. In detection, frontline FETPs can help to identify if there is a signal of a disease outbreak. Intermediate FETPs are equipped to validate those signals and identify real outbreaks. Advanced FETPs can help evaluate and improve weaknesses in the country's surveillance system. For notification, frontline FETPs can help make sure locally that effective notification occurs. Intermediate FETPs can escalate credible alerts and help overcome delays. And advanced FETPs can improve the national notification procedures if limitations are identified. And in response, frontline FETPs can engage in any of the 7 response activities that we showed before. Intermediate FETPs are engaged as well and can assist in coordination to speed up the adoption of those response activities. And advanced FETPs can organize and lead those response activities. I hope now that you have a substantive idea of what timeliness analysis is, how using it can contribute to health security through a process of continuous quality improvement, where and how FETPs are important for 717, and where to get further information, collaboration, and training. I really appreciate your participation here today, your attention, and your work to protect our collective health.
Thank you so much, Dr. Richard. I have rarely seen so many nice comments on a webinar, lots of feedback from people that this was so useful and very well explained. So thank you for that. You have a lot of questions. There are some of them that are asked in other languages, and I want to get to those first because we don't always cover the questions that are not asked in English. So I want to ask just 2 of those. One of them was a question in French. For diseases that require an epidemiologic threshold, even with a single case, can a 717 assessment be carried out?
You can always do a 717 assessment, but if it's an endemic condition where you expect to see some cases, you may not get a lot of benefit if the cases are rare at the moment. It's when they cross a threshold then for a condition that you're seeing frequently, then that's an epidemic. That's an alert that something has changed and we need to do something different. However, I won't say that you shouldn't look at one case. You can always learn something from one case.
Thanks, that's very helpful. There was an early question about Joseph's case, our yellow fever outbreak. If the initial contact with the healthcare system failed to identify yellow fever, but the diagnosis was only made at another healthcare facility 2 days later, which of those dates should we consider for the date of detection?
It's the second one because they didn't detect it in the first place. And this is very common that somebody feels ill, goes to a health facility, gets some pain medicine, and gets sent home without an actual diagnosis. Many times patients, the person may come 2 or 3 times before they get a diagnosis. And there we learn a lot about how to improve detection by improving the clinical suspicion if a condition is important. That's where education works quickly and relatively easily to improve health systems.
Thanks, Richard. I'm just for TEFINET, we're getting some notices that the QR code isn't working, and it's possible, that I put in a wrong QR code. So if you can paste into the chat the correct evaluation, then I think people can do that. So thank you so much. So you can leave the slides where they are, Richard.
Okay.
I just was Yeah, Tuffynet can put into the chat
Yeah, I'm
the
sorry.
right
Okay,
link.
yeah.
No, you're
Uh,
fine. You're fine. So
yeah, yeah.
there are lots and lots of questions, so many. I'm gonna see if I can
May
find
may I may I suggest
some.
that I want to take all of them. If
Please.
we don't have time, I will do them. We will write them and send them out to people.
Yeah. Yep. Yeah, so that is typically what we do, is that
Oh,
you'll
okay.
be responding to them in a spreadsheet afterwards and it'll be posted. So let's start with, we have another question. Is 717 assessed by case or by outbreak?
Um, I would say there's not a difference between those. A case of a disease that can disseminate in the population is an outbreak.
Mhm. But I think the question is, you don't assess it for every case in an outbreak. You would assess it for the first case in an outbreak. Is that correct?
Yes. And in the example from the
Mhm.
Philippines of the 6 different cases, we considered them each an outbreak because they weren't related to the other case. So each of them emerged independently. You could look at them all together, but you learn more from looking at them because they emerged independently, each as an outbreak.
Got you. Thank you. So for folks asking about the QR code, the link is going to be pasted in the chat, so just hold on for that. We have another question. I have seen some 717 calculations use the date of early response action initiation, but measuring completion of early response actions can be more challenging. What advice would you give to someone who is using the date of initiation for early response actions in the place of completion of early response actions?
This is a very good point. Um, so maybe I should have clarified it before. There's sometimes we don't have the right word, so we leave some confusion, and we'll clear it up now, thanks to your question. It's not when you finish doing all the things. An outbreak like COVID went on for years. So we can't say it's that response isn't finished until 2, 4, 5 years later. What we mean is when you have
Mhm.
started all the actions that you're going to take, when you have finished starting them. It's not when the first action
Mhm.
is taken, but it's when the actions that you've decided that you're going to take when you have started them all.
Great, thank you. So somebody is saying, we have another question about date of emergence. Is this the date of onset for the first case, or is it the date when the case gets diagnosed?
It is the date of onset. The first
Mhm.
recognition when you look back, when did it start?
Mhm. So the earliest time that you could possibly have recognized the case is considered the date of emergence. That
Well,
makes sense.
I wouldn't say when
Yeah.
you could recognize a case. Um,
Mhm.
uh, with the yellow fever, with Joseph, he felt bad, and you couldn't recognize a case the day that he started to feel bad. But that's when the case began.
Mhm. Got you. I understand. Okay. What are some possible factors? It looks like what are some possible barriers to meeting the 717 metrics in resource limited settings? And this question was asked before you went through some of those barriers. But if you have a
Mhm.
favorite barrier that you want to bring up, feel free. Otherwise, I'll come up with another question.
Um, no, my favorite barrier is the one I mentioned, which is raising clinical suspicion because it can be done quickly and cheaply or at no cost. With even
Mhm.
resource poor systems have ways to communicate and share information. The modern world is modern because information which used to be expensive and difficult now can be communicated rapidly and effectively. So we can quickly improve detection. Um, the actions of response may require additional resources and coordination, and that's more complex, requires more resources, and may require additional resources. But if
Mhm.
our detection is poor, we can do something quickly for that.
Yeah, yeah. And I mean, I actually really appreciate that answer because low clinical suspicion is a really big problem, and it's a hard one to address when especially when you have a very unusual disease like Ebola, where most of the people you see with a headache or a fever who are coming in, they have malaria. So you don't want your clinician to think that everyone with a headache and fever has Ebola, but you also need them to think about it when they see people with those symptoms who are being treated but who don't get better. So it's a
Hmm.
very tricky line.
Yeah.
For a disease that is lab confirmed, and there's a couple versions of this question, does the early response action of lab confirmation move to the detection metric? I've seen some people use the date of a person presenting to a health facility as a date of detection, even if the case is not yet lab confirmed.
Boy, one of those questions before about
Mhm,
the date of response
mhm,
was really the
mhm,
key point. And here is the other key point for everybody. Um, Detection is, we define this as strong clinical suspicion. You don't know necessarily for sure, but you have reason to believe it enough to notify. That does not require us to have lab confirmation. If we get lab confirmation, that makes it even stronger. But we don't wait for lab confirmation to say, I believe this may well be such and such a thing, and we better start acting now. So, if you have a rapid diagnostic test in the clinic, it may be the same day, the same hour, but all you need is someone who's responsible in the system to strongly believe that this might be a thing to
mhm.
notify.
Thank you. There's a question here about why is 7 days the the number of days that's selected for detection? Does this relate to communicability or something else? How did we decide on 7?
Boy, these are the right,
They're
these
good
are all the right
questions.
comments. Um, Resolve to Save Lives did a review of 57 outbreaks in a variety of countries. And their conclusion was most countries, if they're doing a pretty good job in their health system, should be able to achieve 7, 1, and 7. It's not biological, it's not scientific, it's health systems. Um, Now, if we had 7 days and we could have had 5 days, then 7 isn't good enough. And if we had 15 days and then reduced it to 10 days, even though we didn't hit 7, we are improving. That's the most important thing. But most countries, for most outbreaks, ought to be able to reach 717. That's not a pie in the sky goal. That's a realistic goal in most situations for most countries. And that's why it's functionally very useful.
Thanks, Richard. We have one here that says some countries have mandatory notification for certain diseases, like 24 hours for dengue virus, or a certain number of days for tuberculosis. How does 717 relate to that? Which one do you prioritize or how do you use it?
Uh, for at least 6 different disease conditions, the specialty groups of that area have their own assessment of what timeliness needs to be. So we defer to them for their diseases. Um, some of those are not that practical. Some of them are aspirational. Um, and again, in most diseases, for most countries, you ought to be able to do 7, 1, and 7. If the specialty area in your field says it should be less time than that, that's fine. They're right. It should
Mhm.
be. Can we achieve it? Well, let's see. And more importantly, the trend over time. So you mentioned tuberculosis in 3 days. Sometimes we cannot diagnose tuberculosis, or if they say notification has to be in 3 days. The thing is, tuberculosis evolves slowly depending on where it is in the body and the symptoms. And so that is a slow developing uh, 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 disease, like many parasitic or tropical diseases. And Some of them don't have to be as fast. If something reproduces rapidly in the human population or in the animal population, those are the priority conditions for us to focus on for 717. We don't have to do 717 for every disease. We have to do it where we will reduce the harm the most.
Mhm. Mhm. Yeah, that's actually another question about using it for every disease. So there's a question about, since 717 assesses the timeliness of the overall outbreak response, can it also be applied to evaluate a specific response pillar, like the laboratory pillar or surveillance pillar, or should it always be used across all the pillars respectively? Like, would we expect the lab pillar and the surveillance pillar to have the same thing, or would it just be applied to the outbreak?
This will require local knowledge of your health system and determination of its impact on uh, if it led to additional cases. If it appears to be, for example, a viral hemorrhagic condition and you don't know what it is, so you can't even have a strong suspicion that it's a one condition or another, then you need that lab quickly in order to do the detection. And that should be the priority. We can't specify for all diseases where the lab has to come in. We can say it all has to be within 7 days if we're doing a good job. But for your particular condition, you will be able to determine if a delay in lab meant that detection was slow and response was slow and led to additional cases. So the devil is in the details, and each disease and each country's health system is different.
Thanks, Richard. And for everyone
Julie,
asking about the,
yeah, Julie,
yes,
can
go
I
ahead.
just step in? My
Yeah.
apologies to everyone. This is TefiNet talking. We are having a difficulty locating the link. The QR code is not working. I want to make sure that the interpreters pick this up for the audience. We sincerely apologize. However, we will get this emailed to everyone in attendance on this webinar as soon as possible today. Thank you.
Thanks, Eva. You took the words out of my mouth. I was just going to let folks know that we will figure out how to fix it if we don't during the webinar. So wonderful. Um, there's a question here, Richard, about, in some outbreaks, it may not be feasible to implement all 7 early response actions. And in such situations, how should the completion of an early response system be defined?
Let's say it took 20 days to complete the initiation of early response activities. You look at your health system, you look at the disease outbreak and the accumulated cases that happened, and you say the fact that we couldn't do some action until 20 days either did or didn't affect the response. If it didn't affect the response, then you explain that and you say, we should improve, but it's not the highest priority. If it did affect the response, then you're thinking about the short and long-term actions so that the next time it's less than 20 days.
Got you. Thank you. So here's a really interesting question. Is there any regulation in IHR that specifies that private facilities should have public health officers in place, for example, using the Uganda Ebola outbreak in 2022, to help them improve their detection, notification, and response?
Have public health officers present? No, but it
So,
does specify
yeah.
that the private practitioners have the obligation to notify, just like public practitioners. In practice, this is in many countries a big problem and a major area of need to improve our actions for detection. That's why we included this among the examples of bottlenecks.
Great. We have time for one more question. So this one is asking, in the slide where we showed the multiple disease outbreaks with VPDs and Mpox and some of the others, why were some of the outbreaks detected even before 717? Why did we make the targets in some of them?
In other words, what did they do right?
I think the question relates to maybe the idea that not, I mean, some outbreaks are naturally detected within 717, that they make their targets anyway. And yeah, maybe what did we do right, or what facilitates the detection of outbreaks quickly, even when you're not trying?
Mm-hmm. Well, I'll respond with yellow fever because I know about this in the country, not the case of Joseph, which we invented for this webinar, but the real. Um, have worked with a country that has not had a lot of yellow fever cases, and then suddenly they had one. They hadn't seen it in a long time, and the detection was more than 30 days because nobody knew what they were seeing. Um, and then that information, when it reached the national level, showed them with 717 the need for clinical suspicion. What they did quickly was notify all the different health zones. We have had an outbreak of yellow fever. Look for this, be suspicious, be aware. And there were 5 other outbreaks in other regions that they detected within a day because they knew what they were looking for.
Great. There, I'm going to just ask one more question because I think this is a really interesting one, and it's in Spanish, so I'm going to do my best here to translate. But it's if there is an amount of a quantity of endemic cases, do you count 717 starting from when the outbreak was identified, or when they pass the threshold? Which I think I may not be translating it right, but I think
No,
that
but
that
the
sounds very
question
similar
is
to me. But
question is
essentially,
clear.
how do you handle endemic disease?
Yeah. This again depends on your disease profile in your country. Um, when an unexpected level of the disease occurs, why is that? Did it rise rapidly? Did it rise when in a time of the year when you're not expecting to see it? Um, Somebody saw the data or was in clinics and saw lots of patients and said, this is unusual, this is not expected. That is the spiritual definition of an epidemic. It's like you don't need the numbers sometimes to say, wow, something's happening here that I didn't expect. But the numbers will tell you more specifically. So you can wait till you cross a threshold if that is what your system is designed to do. But you might also see that in a low transmission period of the year, suddenly you see a rapid rise in the cases. It hasn't passed the threshold, but the trend line is alarming. That's enough to say, here we have something, time to learn what's going on and respond.
Thanks, Richard. So just one more time for the folks who said the QR code isn't working, TEFINET is aware of that, and they will be sending you an approach. It looks like she said try one more time. So either way, this will be fixed, so don't stress about it. We're just going to cover a few more things before we close. If we can go to the next slide. So just so you know, there's some upcoming FETP webinars on August 19th. There is a webinar by Dr. Tushar Singh, who I think many of you know, about the effective use of data from FETP investigations. And on September 16th, Dr. Ellen Yard is going to share graphic tips, making simple but effective graphics using Excel and Microsoft Word. We can go to the next slide. As always, if you want your FETP to be featured in the next technical webinar with those photos, please send a photo of FETP trainees in the field to askgwdb@cdc.gov. We always look through them and select a photo for the intro slides in the next webinar. I love getting those, so please send them whenever you have them. Richard, maybe now we could just go back 2 slides because some people are saying that the link is working for them. So we'll give you guys just another 30 seconds to try these. I see Eva also just posted a link in the chat. So we'll give you just another minute to try to use this and to use that link. Otherwise, we very much appreciate your joining us today. We thank our interpreters for the interpretation. please go ahead and use this link to make sure that you get credit for the course. But aside from that, I think we are finished. So thank you again to Dr. Richard. Thanks to our attendees. Please fill out this course evaluation and we will address if you are not able to reach it. Thanks, everyone, and we hope you have a wonderful day.